All right. Good morning, everyone. You're welcome to the Hemodynamic workshop. This is the first workshop on hemodynamic management that we have done for the association. And for today, we just wanted to remember that it's going to be a basic hemodynamic workshop, so basic concepts. And that's why the questions that you just responded to, mostly simple questions you can answer in your sleep. We hope that you're able to finish them, but the purpose for those questions was for you to give us feedback later when you're doing the post-course test to know if we have been effective in passing on the information. So the first talk is going to be generally a talk that covers everything that you're going to listen to today, that you're going to learn today. All of it summarized into the 20 minutes. But the theme for this particular talk is when the body whispers. Hemodynamics are as early signs, early warning signs. And we're going to look at why hemodynamics matter. And we're going to look at that from the physiological side up to the patient level. No disclosures for this particular talk. I'm going to try and make it as interactive as possible so that we both engage. So every deterioration begins with subtle physiological changes. And sometimes the body whispers and we do not listen. And we are going to look at some of those moments when we do not listen and what listening actually means. So it's always important that when there is a reaction within the patient, we're able to detect it early enough. Otherwise, if we do not detect it early enough, then the body is going to end up screaming. And if that's the language of distress that you see, you're probably at the very end of that spectrum. We've always heard of this. The patient's condition changed. And that is perhaps the most common phrase that shows we do not listen to the patient's physiology. So by the end of this talk, the goal will be for us to understand the link between hemodynamic stability, whatever that means, and we're going to look at that, shock and outcomes, and differentiate between the different mechanisms of shock. And then, of course, the bedside clues that you can look out for. Again, these are going to get, the team is going to get, the faculty is going to get into more detail with some of the things I'm going to talk about here. So just bear with me. I'm going to go through this fairly fast. And then, of course, the early physiological signs that precede the compensation. So let's start with when we say the patient is hemodynamically stable. Okay? And I'm going to just ask you to raise your hands. So, patient number one, in a patient who is being treated in the intensive care unit after a suicide attempt with benzodiazepines, mean arterial pressure increases abruptly from 70 to 100 each time the patient wakes up, not on any vasoactive agents. All those in favor that this patient is stable, raise your hands. What about those who are saying this patient is unstable? Raise your hand if you think this patient is unstable. This crowd does, okay, I don't know. If you don't respond, it's very difficult for us to learn together. So all those who think this patient is stable, raise your hands. Those who think this patient is unstable, raise your hands. Okay. Next patient, in a patient who was just admitted to the ICU after major abdominal surgery, systolic blood pressure dropped from 120 to 70 within 10 minutes. All those who think this patient is unstable, raise your hands. All those who think the patient is stable. Okay. In a patient treated for intra-abdominal sepsis with multi-organ failure, the mean arterial pressure has been around 65 under 0.8 to 1.1 micrograms per kg per minute of norepinephrine for 2 days. All those who think this patient is stable, raise your hands. All those who think this patient is unstable. Okay. The blood pressure goes up, the final case, the blood pressure goes up and down in an ICU patient on 0.05 micrograms per kg per minute of norepinephrine after intracranial surgery. All those who think this patient is unstable. All those who think this patient is stable. Okay. So the words stable and unstable are very subjective, as you can see. we are interpreting a critically ill patient. So there is literally no chance that a critically ill patient will ever be stable up until you've gotten them out of the hospital. So we use these words often to mean something that is actually objective within the patient. And that's why it's this paper that was written by Jean-Louis Vincent, who is one of the modern fathers of critical care medicine. He says it's best not to use the word stable or unstable. It's always best for us to refer to the patient by what they objectively have. Is the patient hypotensive? Are they in shock? Are their vasopressor requirements increasing? That's what you refer to. But in terms of stability, a critically ill patient is very dynamic. It's the reason as to why the nurses at the bedside for these ICU patients have to monitor them hourly or every 30 minutes. You have someone there standing by monitoring this patient because they are not stable. So there's no point in time when you're critically ill that we're going to label you as stable. Either your vasopressor requirement is increasing or it is not. Either you're in shock or you're not. Either you're hypotensive or you're not. Okay, so that's the objective assessment that you attach to the patient. So I hope that by the end of today, you'll not be saying patient has been stable for the last 2 hours when they are on high doses of norepinephrine and, or has been unstable yet they have been on very low dose of norepinephrine. Okay. All right. So what is shock? And whenever we say the patient is hemodynamically unstable, what we are most times referring to, either this patient is hypotensive or this patient is in shock. Okay, that's what we are mostly referring to. So what is shock? I want to take us back to the cell level because this is where everything begins. What we see is usually the bigger picture when we zoom out of the patient, but at cellular level, the cell is like a furnace. Okay, and that furnace uses oxygen to burn down glucose, which is the fuel, and burning that down means it's going to generate some energy for you to be able to exert yourselves even now to listen to me, make sense of what I'm saying. Your brain cells are doing that energy for you without even knowing it. And of course, you end up producing carbon dioxide and water. Carbon dioxide, you're going to just breathe it out. Water, you're going to use it for other functions as well. Or if it's too much, you'll just go to the toilet just 5 minutes from now and take it out of your system. So, because the cell is like a furnace, all these things are required for combustion. And so to do that without oxygen means that you're not going to have effective combustion process. And that means that the delivery of oxygen to this cell either has been compromised or the cell itself is unable to take up the oxygen. And therefore, if you remember your biochemistry, applied biochemistry, for those of you who are still in first year, or those of you who are still in third year and you hated that particular course unit, the Krebs cycle becomes extremely important if you have oxygen. Without oxygen, it's glycolysis. And therefore, you end up producing only 2 ATP molecules. Only 2. And that is not enough for you to be able to listen to me right now. If all you're producing was just 2, you would all be collapsed right now and I'll be talking to myself. But all of you right now are generating up to 38 per cell. Okay? So that means that you're able to listen to me because your brain is actually working. So let's discuss. Can a patient be hypotensive but not in shock? Raise your hand if you say yes. Can I be hypotensive but not in shock? Okay. All right. Can a patient be in shock with normal blood pressure? Raise your hand if you say yes. I assume everyone else who is not putting up their hand is saying no. There is no room for I don't know. Okay? All right. Can a patient be in shock with high blood pressure? Raise your hand if you say yes. The numbers have gradually reduced. So blood pressure is what we mostly look at when we are determining if a patient is in shock. This particular study by the European Society of Intensive Care Medicine, not a study, it was more of a consensus guideline, came up with definitions for shock. Shock has nothing to do with blood pressure. has nothing to do with blood pressure. You can be hypertensive and in shock. You can be hypotensive and not in shock. You can be normotensive and in shock. Okay, so blood pressure, while it's what we look at the most to decide, because that's the quickest thing that we look at, and by the end of today, you'll learn a lot more than just blood pressure. It is a very late sign in shock, as we shall see. So the definition for shock as per 2014, and there are new guidelines coming out probably this year, but from the European Society of Intensive Care Medicine, is it's a life-threatening, first of all. It's always life-threatening. If you're in shock, your chances of mortality, if it's cardiogenic shock, is 40 to, actually no, cardiogenic shock is even higher than septic shock. Cardiogenic shock is 50 to 75% chances that you will die. So that means that out of 100 people, 75 of them could actually die. If it is septic shock, it's 40 to 50%. These are very high mortalities. If you try to go to a higher magnitude and say out of 1 million people who have shock, how many of these are going to die? We are talking about 400,000 people up to 750,000 people. If you go to 1 billion people who have shock, that is 400 million people dying. Okay? So that's the magnitude of what you have to think about. So it's life-threatening. Acute circulatory failure. And before we used to say due to inadequate oxygen supply and therefore impaired utilization. But the new definition of 2014 seemed to have simply gone to inadequate oxygen utilization. That's when you're in shock, because typically what tends to happen if your blood pressure has dropped or if you're going into a shock state, your body initially first increases this capacity to utilize oxygen before it fails, and then you end up into shock. So that is cellular dysoxia that happens in shock and leads to physiological dependence between oxygen delivery. A loss of the physiological dependence is when you actually end up in shock, and not necessarily that you have reduced delivery per se. So we compensate a lot for the shock, and the younger you are, the more likely you are to compensate for it. But using an example of hemorrhagic shock, this is a paper published in the New England Journal of Medicine back in 2018, and you can see that you have to lose up to more than 1,500 mils of blood. This is for adults, not for children, to be able to see a drop in your blood pressure. So this whole time, the blood pressure is still normal. And you have to lose up to 1.5 liters of blood to actually manifest a drop in your blood pressure. By then, it's a little too late, like I mentioned earlier. So some of the things that we use to diagnose shock can range from the clinical signs up to imaging. And clinical signs, I think we shall go through this as well with other sessions. But altered mentation tends to be quite common, especially in the elderly population. And then, of course, cold clammy peripheries, delayed cup refill. Renally, we tend to see reduced urine output. Hemodynamics, tachycardia is quite a quick reaction to shock. It makes it extremely sensitive and not specific enough. Of course, if you look at the BP, which is a late sign, like I mentioned, we tend to say MAP of less than 70, or systolic less than 90. And biochemical signs, as we shall see later, lactate tends to go up as well. And we have a cardiologist in the house who is going to take us through the echo images of a person who is in shock. So based on the European Society guideline, they say the presence of low blood pressure is not a prerequisite to defining shock. Compensatory mechanisms may preserve blood pressure through vasoconstriction, while tissue perfusion and oxygenation are already decreased significantly. So hypotension is more or less the thunder after the whisper. It's not, by the time you see it, it is not actually an early sign, it's a late sign. And if you think about the cardiovascular system, because today is about hemodynamics, think of yourself as a plumber, and the next talk is really going to delve into the pipes, the pumps, and the pressures that exist within this cardiovascular system. But a brief one, we have two broad mechanisms of shock. One is macrocirculatory, which we all know, and there are majorly 4 types. If it's not the heart, which is cardiogenic, it's probably the blood vessels, which is what we categorize as distributive. It is not blood vessels. it is the volume within the blood vessels, and that means that is hypovolemic shock. And if it is neither of those, you probably have an obstruction to the flow, which is what we consider as obstructive shock. And whenever we're at the bedside, we always have to think, when we see a patient who is exhibiting potential signs of hypoperfusion, we have to think of those 4 macro mechanisms that could be present. And we should always remember that there's usually more than one mechanism present, and we have to eliminate by exclusion all the other potential mechanisms. Otherwise, you miss the one that is potentially there, then the patient still dies. The advantage here, that the data that we have at the moment, is that we know hypovolemic shock and obstructive shock have the best outcomes because all of you usually give fluids. Who has never given fluid there? One has never given fluid there? Okay, anyone else? So all of you give fluid, that's why these patients survive, okay? But when it's cardiogenic shock, it becomes a little bit trickier. If it is septic shock, it becomes a little bit trickier. So obstructive shock, the treatment is usually obvious. If it is a tension pneumo, if it is a pericardial tamponade, the treatment is usually quite easy. If it's the PE, easy. Of course, if you don't have the drug, it's not easy. So these are the physiological this is a physiological backbone for all these mechanisms of shock. If it is hypovolemic, you have a reduction in volume, therefore your preload drops, and shall listen to that. Cardiogenic, it's the pump failure. Distributive, it's the blood vessels being dilated. It's obstructive. It's really blocked flow. And the changes that we usually see clinically can range from looking at the neck veins, the JVP, telling you if the JVP is elevated, I do not expect you to tell me that this patient has significant hypovolemic shock. There's something, it could be there, but there's something else that's causing the JVP to go up. If the skin is warm and the patient is showing signs of shock, the capillary fill time is elevated, and then you tell me this patient has obstructive shock, I'm going to have a hard time believing you until we are absolutely certain there's nothing that is causing vasodilatation in this patient. So the most common type of shock that we see globally is going to be septic shock. That's because infections are rampant. Even within our own setting, infections are a lot more than trauma. But in our setting, probably trauma leading to hemorrhage will potentially increase the hypovolemic shock at this point. So always remember, rarely does one mechanism of shock exist on its own. Always look for the others. The other aspect that I'll not delve much into is microcirculatory shock. And that's really at the capillary bed. And this is the view of the capillary bed, a normal one. And you can see that you can see the blood vessels, the capillaries, the blood cell. You can actually see the red blood cells moving through the capillaries pretty well. And then there is another, this is an electron microscope. And they've adapted the electron microscopes now to be potentially able to be used at the bedside. You just point it under the sublingual area and you're able to see that level, and it gives you a much earlier detection of shock. So, as we wind up, the clinical whispers that we have to always think about. Thank you. Thank you very much. The clinical whispers we always have to think about, since I'm winding up, I will not use it. Altered mentation, like I said, is mostly in the elderly, and sometimes this is all the elderly patients present with. They come into the hospital and the family is complaining that they've been confused for the last 12 hours. And that confusion, you have to be very careful. The elderly patients, immediately, the moment they get into hypoperfusion, they just become a little confused. While the younger patients remain extremely lucid, and you just find them with cold periphery, but they know what's going on, they understand everything, and then you take them into a state where you have to reduce their mental status, and everything just crashes because you take away their sympathetic tone. Tachycardia is also quite a common one, although it is extremely sensitive, that even just mere pain can cause a tachycardia or anxiety, or so capillary fill time is fairly more specific than tachycardia, but compared to most of the parameters here, it's quite a sensitive parameter. Pulse pressure, we shall talk about that later as well. And then oliguria tends to be the global indicator of shock. When you have oliguria, it tends to be the one. And then, of course, a rising lactate, which, again, we shall talk about later. When you when you get when you get the whisper in any patient, always respond with the ABCD approach, because that will help you identify the life-threatening conditions that exist in other systems to be able to deal with them. And always remember to treat the cause. And if anything you're going to take away from this particular talk will be these three things. The body whispers long before it crashes. Hemodynamics usually translates physiology into survival. And then finally, early recognition and response saves lives. So it's not just about the technology you're going to see, it's about your clinical acumen as well. So thank you for listening. I hope that we can interact later.